Over the next 25 years, the worldwide incidence of cancer will increase by 75%, which equates to over 35 million cases and nearly 19 million deaths. Over 70% of these new cancer cases will develop in low and middle income countries, such as those in sub-Saharan Africa, where 2 out of 3 patients with cancer go undiagnosed, and they commonly present with advanced disease. Even for those patients who have the same type of cancer, outcomes vary substantially both within and between the countries and world regions. Driving these inequalities are geopolitical and socioeconomic factors, access to therapeutics and other modalities, misinformation and cultural beliefs, and vulnerable populations, including those living in conflict areas.
Solutions to address this global crisis are complex, but a common denominator is a well-trained, diverse workforce. This includes all members of the cancer care continuum, from community healthcare workers, nurses, and technicians to specialized healthcare providers and physicians.
In Latin America, the cancer workforce crisis is closely linked to fragmented care pathways, delayed diagnosis, and unequal access to timely treatment. Many patients reach specialized cancer care too late, after moving through poorly coordinated systems from first symptoms to referral. National cancer control plans are not yet universal, and implementation, financing, and comparable data remain inconsistent. The response must be coordinated and funded. Stronger cancer plans, cancer and workforce registries, clearer referral pathways, and training for primary care and community health workers. Collaboration with better resourced regions can accelerate progress through sustained partnerships in education, implementation research, technology transfer, and institutional capacity building. For Latin America, the call to action is clear. Workforce planning must translate policy into earlier diagnosis, timely treatment, and more equitable outcomes.
When we talk about cancer workforce, we tend to picture oncologists, surgeons, or radiation therapists, or more broadly, clinicians. But some of the most critical work in cancer care remains largely invisible. Across many countries, it is the nurses, social workers, patient navigators, palliative care teams, community health workers, volunteers, and also family caregivers who keep patients connected to care, especially when the system becomes fragmented and overwhelming. Much of this work is highly relational, emotionally demanding, and disproportionately carried by women, both formally and informally. Yet these roles are still undervalued, undercounted, and often excluded from workforce planning. If we want resilient cancer systems, workforce planning cannot focus only on who delivers treatment. It must also recognize who keeps patients in care, who holds teams together, and who prevents people from falling through the cracks.
The population of Asia is greater than any continent in the world, and as a result, almost 60% of the global cancer workforce needs are in this region. In Asia and Oceania, workforce scale-up in diagnostic and imaging areas and cancer surgery would have the greatest impact on improving cancer mortality. A comprehensive workforce scale-up would potentially save 115 million lives in Asia between 2030 and 2050, and 600,000 lives in Oceania, which indicates the dramatic impact of workforce change on patient outcomes. In addition, the return on investment from life years gained through improving cancer workforce numbers was calculated to be almost $4 per dollar invested in Asia, while in Oceania, it would be almost $10 for each dollar invested. These results highlight the compelling case for training and increasing cancer workforce numbers in Asia and Oceania, and globally.
This Lancet Oncology Commission identifies the key elements necessary to develop an oncology workforce with the scale required to meet projected global cancer burden. A comprehensive, financially sustainable scale-up of workforce capacity could decrease cancer-related mortality by approximately 40% worldwide, yielding a global return on investment of $4 for every dollar invested. So, with this in mind, we issue a call to action and set priorities for country-specific strategies for building teams based on data, the redesign of workforce utilization, acceptance of task shifting to trained health professionals, the use of novel technologies such as AI and digital health, the future proofing of medical education, and the design of a sustainable health system with resilient, robust public-private partnership at national and international levels. Thank you very much.